Thank you, Dr. Mohammed Bashir, for a very interesting talk, very interesting and informative presentation. Now we're going to start the questions. My first question to Dr. Sara Sulaiman: can some diabetes medications amplify the immune response to COVID-19?
So I assume by amplify you mean improve the immune response. So metformin is the classic one, it's being studied. SGLT2 inhibitors, their study's going to report soon. They both work on the innate immunity and theoretically improve the immune response to COVID-19. The issue, however, is metformin's associated with lactic acidosis and SGLT2 inhibitors with DKAs. So in a really sick patient, I think it's definitely sensible to stop them, insulin being the mainstay of treatment. But there is no harm in reintroducing metformin in someone who's stable. And for the SGLT2s, I think, watch this space. I should say DPP4s, there's a good Italian study looking at DPP4s suggesting that they have a beneficial effect, but it appears that that's probably much more related to socioeconomic status than anything else. People who can afford DPP4s are people who are able to buy the drug and by definition have better healthcare. So jury's out.
The second question to Dr. Sara: diabetic patients who had already recovered from COVID-19, are they at higher risk of developing COVID-19 again for the second time, more than normal population?
I don't know that we have any data to support that. I think what we do know is that people with poorly controlled diabetes glycate their ACE2 receptor. They glycate the spike protein and they make them both stickier. And that makes them likely to get COVID the first time. I don't think we even have the data on who will get, non-diabetics, the whole world, who will get COVID twice. So it's difficult to say, but if there is a susceptibility, then arguably people with poorly controlled diabetes will be the people who are more likely to be affected.
Okay. We hope that no one will get COVID for the second time. The questions now for Dr. Naveed Sattar: is there any role of GLP-1 drugs in prevention of development of high BMI and pre-diabetes? GLP-1?
So in terms of licensing, clearly we're a long way from licensing drugs for pre-diabetes, but the recent, in terms of GLP-1, people should look at the recent STEP trials, which are very interesting. Of course, that was with semaglutide. With oral GLP-1, I'm not aware of any trials, but I suspect there are. But the problem in pre-diabetes is to prevent diabetes, in my personal view, is lifestyle-based, because once you're on a diabetes drug, it's hard to say that you prevented something with a drug that prevents, keeps sugar down, if that makes sense. So it's a bit of a semantic, but it's a bit like, metformin prevents diabetes, but metformin also lowers sugar. So what happens when you stop the metformin? I think as your community goes forward, I don't know what you're doing. I mean, I have no sense of what's happening in your community in terms of a diabetes prevention program. But for me, in the area of pre-diabetes, lifestyle first and foremost is, it does work. The key thing is to identify the right people at the right time, offer them the lifestyle changes and encourage them to do so, to try and delay diabetes for 3, 4, 5 years. Because even if you're able to delay diabetes for 5 years, you might get substantial benefit.
The second question for Dr. Naveed Sattar from Dr. Ryan: what about exercise? Is it just walking? For how many times per week? And the duration you advise?
Well, I mean, no one's done a different trial by different levels of exercise, but activity levels do work because they improve your muscle mass. Again, what I would say to people in the community, for me, the best evidence in the combined trials is that weight loss is associated with outcomes. So I suspect the biggest benefit that people can sustain is going to be dietary change. But having said that, if people want to walk more, then what they should aim for is whatever step count they're doing every day, increase it by 1,000 or 500 a day, an extra 5 minutes a day walking, or an extra 10 minutes of a day walking, which is achievable and sustainable for most people. And once they do that, as they start to get a bit more physically active and their muscles are better, they can then increase it by another 5 minutes or another 10 minutes. I try and aim for about 8,000 to 9,000 steps a day. And I think that keeps me in good health, and it also stops me eating as much. And so it's simple. And if they get bored walking, walk with a friend if you can with COVID, or put on a podcast, or change the variety just to make it fun and enjoyable. Those are the key things. Sustainability.
Again, for Dr. Naveed Sattar from Dr. Zahra, I would like to know glucophage tablet will help in the prevention of type 2 diabetes in obese children.
Glucophage?
Yeah, her question is, do you think it will help in the prevention of type 2 diabetes in obese children?
Well, again, I would go back to the answer is, it does work, but again, it depends what you want as a country. For me, the ideal scenario would be to change the food policy of the country to stop the chances of having more obese children in the first place. If you've got a child who's starting to develop diabetes, it's a disaster. It's a disaster. 10, 15-year-old developing type 2, lifelong hypoglycemia. We also know they tend to be more insulin resistant, more obese. The beta cell function declines faster. They get more rapid, Mohammed will confirm this, they get more rapid kidney disease. They get rapid glycemic deterioration. We all know this. So it's a disaster in every sense. So I think if you are seeing a lot more obese children, I think you need to think about upstream public health policies as my...
This is it has to go to these specifics of patients and what medications they're on. So it's not possible to give a huge umbrella advice during Ramadan, and depends on the fasting conditions as well. So you can't have one answer for that. So the lower the EGFR, the better. It's better not to fast. However, diabetic kidney disease, as said, has a huge kind of multiple stages, and an EGFR can vary from 90 till 30. So those patients with a preserved EGFR, I don't see a problem with them fasting. But those with a lower EGFR, I think fasting.
Those patients who are fasting Ramadan and taking SGLT2?
All right. Again, I have an issue with Ramadan studies in general, because Ramadan does not mean the same thing in every place. So if we're talking about our area here, it depends on many factors. How many fasting hours you do, and what type of temperature you're exposing yourself to. There have been some data that came from UAE as data showed that it's actually quite safe to use SGLT2 like canagliflozin during Ramadan with no problems. However, if somebody is working in the sun, exposed to heat all the time, and it's long fasting hours, I will advise either not to fast or to hold SGLT2 during Ramadan. But somebody else doing office work and doing the reduced working hours that we have over here, it should be fine. And it's being shown within these conditions that it's fine to use them.
Okay, from your experience, Dr. Mohammed Bashir, do you think that most patients who have developed diabetic nephropathy, they end up on dialysis or not?
No, the percentage of them that end up in dialysis is actually small, but the problem, as just been highlighted in the presentation right now, is that diabetes is being diagnosed early, and there are some very gloomy data that didn't show that the younger the patient they develop diabetes, you might be able to reduce multiple risks in the future. However, you will have very little influence on their risk of developing kidney disease or end-stage kidney disease. So the incidence is increasing because of multiple factors, as I just told you. One of them is the very young diagnosis or early diagnosis of diabetes, particularly type 2 diabetes, and in the population, especially again in our part of the world.
Okay, I think this is all the questions. Thank you all for being with us today. I'll get back to Ahmed.
Thank you.
Thank you very much for having us.
Thank you.
Thank you. Thank you very much.
Enjoyed it. Bye-bye.
Thanks very much for the invite.
Thank you.
Bye now.